All right, everybody, we'll go ahead and get started, and we'll do quick brief overview of what today will be like, and then we'll go get started with the presentation. So the session is going to revolve around the QI projects from Cabin Creek and New River. Natasha, I see you're the only one on, so maybe we'll start with Cabin Creek, and then hopefully others will connect if they can. If not, it'll be the Natasha show for New River. But that's okay. We're not gonna do breakout rooms. We're gonna do them here so everybody can listen and provide feedback. So remember, brief 5-minute. This is what it is. This is what we're hoping to do. This is where we're at. And then we'll hopefully be able to answer any questions you have. Think about next steps for your group, and anything like that. So I think we can turn it over to Bridget and Emily if you guys are ready, and we'll let you take it away.
Sure. Bridget is our team lead and she has taken this project on, so she'll be presenting today.
I also created like a PowerPoint, so I'm going to attempt to share my screen if y'all would like to see that. I hope you do, because like I worked a few hours on it.
Oh, heck yeah, we want to see that. Yeah. We love PowerPoints.
That's awesome. Yeah, you should be able to do it.
But sharing my screen might be a challenge, so let me look. It's been a while. Okay, share screen.
Yep, green button. Then you pick the screen that you want to share. You should see your presentation or your desktop, either one. There you go.
All right. Is it there?
Awesome.
Yeah, sure is.
Okay.
Perfect.
Okay. So our quality improvement project, we had talked about that before. It was improving MAT patient engagement with primary care. Our QI team, we have Emily Hanna, who's the CARP program director, Ananya Brown, she's a medical assistant and also a patient care representative. Kathy Darby, she's the medical assistant. She's been here for a long time. Katie May is a new clinical psychologist. And me, I'm the care navigator and also the data collector. As a disclaimer, this data has just kind of been thrown together a little bit. I don't know who a numbers person would be outside of, in the private sector. Normally we would have statisticians or epidemiologists look at this and make it nice and pretty. So there's probably going to be some calculation errors. Don't point those out because it'll hurt my feelings. Okay, so the reason we chose to increase the reason we chose the project to increase MAT patient enrollment or engagement with primary care is because we want to make sure that patients are focused more on just their substance use disorder. We have patients come here who this is the only care they receive from a medical standpoint. They have blood pressure issues, cholesterol, not receiving cancer screening. So we really want to make sure that patients are looking at their whole health as a whole person instead of just their substance use disorder. A lot of times patients will bring things up that can't be thoroughly addressed during a MAT program or a MAT appointment, and they're a little bit more acute needs like STI testing, or if they're having some psychiatric problems and need a referral to a psychiatrist. If they don't have a primary care doctor, then they can't really get that taken care of as quickly as they could otherwise. And we have a lot of patients who want testosterone testing, and we can't really do that here either. And then the most obvious reason, from day-to-day workflow is that when patients are needing these primary care needs met in their MAT appointment, they're extending the time that this appointment happens, and then patients are just here for longer than they need to be because you have one patient ask for something and then someone else asks for that. They're like, oh, I need that too. So we want to kind of decrease the prevalence of that. Our methods, the QI team met one time to discuss how we can increase this number of patients who are going to primary care. We use the nominal group technique, which I think was pretty helpful in helping us to narrow down our choices. We had different ideas. You can read them here. Some of them, the top 3 was adapting the MAT appointment around the primary care doctor appointment, have the care navigator do reminder calls, and find a CARP-minded provider that works quickly to get patients in. Our action plan was to, for the first rapid cycle, we decided that the care navigator would formally discuss with patients one-on-one that they can schedule their PCP appointments around their MAT appointment. Prior to this, a lot of times we would kind of informally talk with patients about their primary care needs, ask them to please make a primary care appointment. This would often happen in group when they were asking for something that we couldn't accommodate, or if the care navigator was just having a conversation and they might try to encourage the patient to go to a primary care doctor, but there was no formal follow-up or anything to see like why the patients were not going to primary care. We also decided that the care navigator would be responsible to follow up with the patient to see, what happened. Like, did they actually go to primary care? Did they not? What happened? Why? So the data collector chose 3 groups of people, 3 med groups to serve as the sample size. We had 39 patients across these groups. They're in all different, the patients were all in different phases of recovery, had different levels of socioeconomic stability. Some were employed, others were almost homeless. But all of the patients were either in IOP phase 1 or phase 2 of our CARP program. So that means they're either coming several times a week, once a week, or once every other week. After we selected those 3 groups of patients, we further created a line list of patients and further separated them into 2 different groups. We had patients, we separated them into patients who had a primary care appointment in the last 12 months and patients who did not have a primary care appointment in the last 12 months. That just kind of helped to give us some black and white data of what we were looking at. Some acronyms you'll see on these charts. Work group is we meet once a week in the evenings. Patients from phase 1, 2, 3, or 4 are in this program or in this group. And for our purposes, we selected only patients who were in phase 1 or 2 to be in the sample. IOP patients with stimulant use disorder, primarily methamphetamine, patients who use fentanyl, benzos, and alcohol, they'll come into this program and come 1 to 4 or 3 or 4 times a week, depending on what medication they were or what illicit drug they were using. And then Friday AM, that's just a general med group, and patients can be in any phase of the program except IOP. And then for this project, we only use the patients who are in phase 1 or 2. So here is an overview of our baseline data. Again, we separated it into patients who had a primary care appointment documented within the last 12 months, and then the total number and the percentage. And then we had patients who did not have a documented primary care doctor appointment in the last 12 months and the percentage. It's divided into IOP versus work group versus AM patients, but I think what we'll focus on right now is just the total over in the far right column. We had 39 patients. Of those, only 14 had a documented visit within the last 12 months. That's 36% of our total. And 25 did not have a primary care doctor appointment in the last 12 months, and that's 64%. Any questions so far? Okay. So our goal was very ambitious. We wanted to increase the overall patient engagement with primary care from 36% to 70%. So we wanted to go from 14 patients who had a documented primary care visit and increase that to 27. So 36 to 70% sounds like a big number, but I guess we were thinking 14 patients to 27 didn't seem like that much. And then we wanted to decrease the amount of patients who didn't have a primary care doctor appointment to 30%. So the outcome of the rapid cycle, the first rapid cycle, the care navigator would talk with patients in each of the groups and ask them about, their primary care provider history, have they been, would they go, can they make an appointment? What we determined after reviewing the data was that we had an increase to 41% of patients who did have a documented PCP visit. So we increased our total number by 2. And then the percentage who didn't have a documented PCP visit went down to 59%, and the numbers we had 23 who still did not have a primary care visit in the last 12 months. So this is an overview of our baseline versus the goal versus reality. We wanted 27 patients to have a primary care doctor visit in the last 12 months, and we ended up with just 16, which is, 2 more patients. So these numbers are not terribly robust, but at least we were able to get 2 patients into care, right? So we did a deeper dive into the data and saw that we really didn't get those 2 patients into care. They were patients, these 2 patients were actually in primary care in another facility. So when we collected the initial data, we went through the 39 patients and looked to see if they had a primary care doctor within the Cabin Creek Health System. And those who did not, we just categorized into the has not had an appointment. But then it turns out that they actually see primary care elsewhere. So, the data kind of looks like we got 2 people into primary care, but we actually did not. So this is just an overview. I won't go through it all. This is probably the more important part of the data, and also the one that I'm not sure if the numbers are completely aligned, but we're looking at why weren't patients scheduled for primary care in the first rapid cycle. And just to have some black and white numbers, we did have 6 patients that fell out of care completely. So we are not sure, didn't have the opportunity to engage with them. We had 9 patients that the care navigator just did not engage with the patient, but they are still in care. And then there were 6 patients that the care navigator was able to talk with the patient about primary care, but the patient did not make the appointment. Some of the reasons this patients did not schedule a primary care doctor, there was a lot of patients that had other immediate priorities. One had a family member who passed away. One patient just did not want to know what their primary care doctor had to say. They were, concerned about other health issues and I guess preferred to turn a blind eye to it. We had another patient who was on the verge of experiencing homelessness. So with some of these patients, primary care is not their first priority, and that's understandable. And overall, the reason we didn't meet our goal was, I think it had ultimately to do with staffing. We had a 3-week rapid cycle. It started October 31st and went through November 18th. And within that time period, several staff members were off on vacation. Some were sick. So we really didn't have our whole team together to help meet this goal. And I think we didn't consider that, when we're having these numbers, there are patients who fall out of care. The cycle was fairly short. We did have 1 patient who made an appointment, but it was scheduled outside of, the rapid cycle. So we couldn't include that in our numbers of, patients who who went to a primary care appointment. And also, I think ultimately, probably we could have started with patients who were a little more stable, such as patients who might be in phases 2 or 3 of the program. Normally, their lives are just not as chaotic. They're not dealing with, I mean, a lot of them deal with all kinds of different things, but patients in phase 2 or 3 tend to be more employed, stable, housed, that sort of thing. And then with our next action plan, we, I think what we'll do is just kind of adapt our current methods, because we didn't really have a good cycle since a lot of staff members were gone. And we'll just kind of include different groups and care navigators who are involved. And then ultimately we'll need to figure out how to definitively track our PCP engagement, if that's something we want to track. Any questions?
No, well, no questions necessarily. First, I just want to say, Bridget, fantastic job. What a great presentation. And
Thanks.
loved your slides, and the data people on the call were laughing along with you when you were talking about your data points. Two comments I have. I just really want to, your team, your QI team is a perfect example of what we're looking for, because you had all kinds of modalities in there. You had folks on the administrative side, then the medical side, the therapy side. I loved how well-rounded your team was.
Mm-hmm.
And the goal you picked, I also, it was such a great example of sometimes we pick a goal for this good reason, but then there's also these other positive benefits. So you talked about, ultimately the goal is that you want to help your patients, get connected to more care so they can get more medical care. And then the additional sort of side benefit of that is those folks are currently taking up some space, and MA&T appointments are taking more time. So when you give them that resource, that's actually going to positively benefit the program as a whole and the other patients in there. So that was just a great goal.
Yeah, I agree. I just made a couple notes as I was going through. A great presentation, great project. When you started out and you were deprecating about the statistics and needing a statistician or an epidemiologist, that's not true in QI. What you did is exactly what you're supposed to do. That's the point of QI. It's not research. You're not proving a correlation or causation. You're really just trying to move a needle or trend. So don't ever think that you need more than what you already are and what you're already doing, because you're doing exactly the right thing. I thought that it was I was really heartened by the fact that when you did the deep dive and you thought, well, they really were already linked to a PCP outside. That, to me, that signaled that it wasn't necessarily about Cabin Creek making more money or getting more visits, and it was about the patient truly getting care, and that you truly cared about them seeing a PCP regardless of where that care was delivered, which is really nice. But I will say that it's not bad to try to recruit patients into your clinic, your primary care, because there is an argument to be made for coordination of care. And I mean, I presume this to be true because it's true in our system. If someone goes to a primary care, internal med or family med, I can see the notes as the MAT provider, and that sometimes gives me great insight, and I can coordinate their care better. So if quality care is delivered and a patient is accepting of coming into your system for their primary care, I think that's a good goal in and of itself for, holistic, person-centered medical home kind of care. So, and then finally, I think I think your cycle was way too short for, and that's why, you weren't happy with your numbers. It's 3 weeks or whatever that was, way too short. I think over time, this is just me personally, and this is kind of instinctual, and I'm not really looking at a deep dive on it, but I would say at least 3 months would be a better time frame to look to see if you're moving the needle. But I think you will in 3 months for sure. I really do, because you moved the needle a little bit. I mean, even though they had already had a PCP outside that they had seen, you move the needle of having them internally see your one of your providers for primary care in just 3 weeks, which is pretty amazing. So great job.
I agree. I think the other thing one of the data points you mentioned was the 6 people that fell out of care. you might want to think about what your average dropout is for a month and take that into account, because you had 39 patients, I think. You've -6, you're at, do the quick math, all that, you're already at that, percentage. You actually are closer if you take that into account, that's what's going to happen regardless of how long your cycle is, or 3 months like Tony said. So I would keep that in mind as well, because your numbers are going to look different. Any other comments from anybody?
Oh, I thought you guys are really aiming for the stars there with the 70, like your goal was 70% in 3 weeks. Like, you are powerful. You're a powerful group of people. It's impressive. I love people that reach for the stars. It's awesome.
It seemed more attainable at the time. I don't know. I don't know what I was thinking.
That was
Especially
before
since
we
we were
all
all
got
scheduled to be
sick.
out.
Yeah.
I think it's a great project though, and I agree with Tony. Too short, for sure. And don't beat yourself up yet, because you have plenty of time to continue on. And if you don't get to 70%, even if you're moving that needle up, that's good. So great job.
All right, Bridget and Emily, thank you so much. Really appreciate it. Great job on the slides. They looked great, very helpful. Okay, I think if there aren't any other comments, we'll throw it over to Natasha and Tommy, and you guys can walk us through your project.
Okay, well, I shouldn't have went after Bridget. That's all I'm gonna say. I do not have a PowerPoint or anything like that, and we are currently in the middle of our project because ours is a 4-month project. Right now we are in the week 5 to 8. So I do have our project charter that you guys can look at and see what our goals are. I just started collecting data this week on missed appointments. So our first week 1 through 4 would be attend behavioral health, group therapy, and group med management. So this is a contingency management program. And what we did was I tracked the appointments that were missed. And if they didn't miss any appointment in that 1 week, they got like a small contingency management prize, which was like chewing gum, chapstick, candy bars, etc. And it was a very positive outcome that we did have. The data I'm collecting now is also, I find it to be the same patients are getting the incentives regardless of the program in the first 1 to 4 weeks. There's the same people that never miss their appointments to begin with. I think the second 5 weeks, or the second step, is what we're on now. We're 3 weeks into that. We have seen quite a bit of a difference. Oh, let me pull that up. With some of our patients. So in this section of our contingency management, we are doing missed appointments and clean drug screens. And this week we have had more than we've ever had to be clean in our program. So we've had, it was 1, 2, 3, 4, 5 clean drug screens today in our group of 9 people. So that was a pretty big deal. Okay, so like we said, our executive sponsor is our chief medical officer, which is Angela Barker. Our change leader is Jennifer Boyd, who is the PA for our weekly groups. Our change team is Tommy, myself, which I'm the case manager for the weekly groups. And then Andrew, who is the therapist. Our counselor, and our mat nurse, Regina. We did not get a chance to meet this month. It's been a little crazy. I had the flu and then Thanksgiving and all that jazz. So I have been collecting data on the number of overall appointments missed. She wants me to do it by patient and patients in general, and then just a number at large, I guess. So our goal was to increase to 75%. So I'm not sure because we just started the baseline data collecting this month for the month of September, and that was our goal, is to compare September to our next three months. So our read cycle or rapid cycle number 1 started October 13th and it ended on October 10th or November 10th, sorry. So our plan was to do incentives to help people keep appointments. And we gave them $1 to $2 incentives for keeping appointments. And the study was to compare to attendance in September. So that September will be our baseline. Our rapid cycle 2 started on the 10th of this month and will end on December 8th. So like I was saying earlier, we're going to do incentives to help people screen positive for BUP every week. And then for our due, we're going to increase the incentive amount. So it's going to be like a $2 to $5 thing, which we're in the middle of right now. And that would be for negative drug screens. And then our study was to compare screens in September once again. And our third, which is December 8th through January 5th, do incentives to help people keep appointments, screen for BUP, and attend meetings. So we require 4 meetings a week for our weekly patients. 3 of those have to be in person and 1 is online. And that would be, the due would be to give like a $5 to $10 incentive for 4 meetings and a negative screen. Gosh, sorry, I've got a small baby child here. He keeps screaming juice. And then compare screens to results once again in September. So I did go through all of our September behavioral health so far. And then next I'll continue to look at all those other missed appointments, but it's quite a bit when you're the only person looking at those appointments. And I was just trained on Athena, so that's fun navigating that. So I don't know if you guys have any questions, or Tom, you have anything to add to that?
Well,
No, I'm still in the van, so I heard everything you said, and sounds good, but literally just pulled up to a Whipple here. So yeah, we had a patient that had some issues today, and now I just got them home. So I joined the meeting late, so I apologize. But I heard everything Cass said and kind of came in halfway through the other person's share there where they are with theirs. But yeah, I really don't have much to add. But good job, Tash.
Thanks, Tom.
First of all, great presentation. You also presented way better than I would have if I had a kiddo in the background asking for you. Didn't skip a beat, so kudos to you. And love your goals. And I could see how each of these really complementing each other so well, right? So your goal of trying to increase attendance, of trying to have negative drug screens and then attend more peer recovery meetings. I can see if you're helping them address this one, I could see those really positively affecting the other 2 as well. So great teamwork.
Yes, thanks. I think our goal is to start out small, because in Jennifer Boyd's mind, she has a bigger project coming after this. So we wanted to kind of get the feels for what we were trying to obtain with our patients. And I think starting out small is probably a good way to go.
I also wanted to say, I think it was also really smart to pull baseline that is as recent as you can, because then you have a really comparative data, because, you know, comparing this month to like 2 years ago is going to be totally different than you comparing 2 months ago. So I think that was really smart to pull as recent as you can.
Who else has a comment?
Yeah, I love the project too. And I love like this kind of what Katie was talking about, like you have a stepwise approach. And I love that you have defined your rapid cycles, like, you know, week 1 to 4, that's the first rapid cycle with your defined measures, week 5 to 8, that's your second, but with the overall goal of comparing September to the end of the project, which is really what rapid cycle improvement is all about. And so I think you did fantastic. Just a tip as you're going along, like learn from your rapid set, like if there's anything that pops out of like what's working and what's not working, and measure. I frankly think data collection is the hardest part of any quality improvement project, and figuring out how to extract what you're looking for from your EHR or whatever database you're using. So, you know, good for you I used Athena in the past too, and I didn't. You can't, you know, you can set up with the vendor certain, you know, they will set up certain data points for your data dashboard of what but I didn't find that really easy to do. And I ended up having to do a lot of that extraction myself. So good for you for doing that. And I really love how you've cut it up into segments as you go towards the goal from, you know, point A to the end of the project in 4 months. So good for you. I'm sure you get a lot of really interesting information and see what is really impactful, and what influences you know, which behaviors are the most influenceable by whatever little award or initiative you're giving. I would be interested in hearing what you find out.
I will. And so far, it's the larger incentives have created clean screens. And that's our goal ultimately.
That's great. No, I mean, great presentation. I agree. I like how it's all split up, very structured. But I also like Tony's comment about you're going to find things in those windows of where you're doing the cycles. And so being able to then adapt it for the next one. So you know, like, oh, well, this is not working. Okay, you know, the next one we're going to do something different, or this really works. We're going to add, you know, I think is a great comment, because that's something I think as a team we were struggling with, right? If we all remember when we first started, we were going down the road and we weren't checking it off enough. And then we finally figured out like, oh, we should stop doing this and do more of this. So, you know, so I think that's a great way to kind of cut it up and then learn from all those different cycles you're doing.
Awesome. Thank you guys.
Thank you. All right, so this is, although our last echo session for QI for this cohort, that does not mean you lose access to the group. So we want to make sure that you guys know that we obviously are available via email. We can set up short calls, you know, whatever works best for you guys as you're going down, you know, your QI journey here. You know, we're here to help. You know, it's awesome that we can get the group together, and we've done that 6 times, and we really appreciate you guys being here at 5 o'clock all the time. But now we are at your disposal when you need us. So please don't be shy. We're very interested to see how the projects go and help out in any way we can, whether that's data questions, setup questions, you name it. We're here for you. So please don't be shy. I think everybody should have our emails from the recap emails and things like that. So, but if you ever have issues getting a hold of us, you know, one of us will get back to you for sure. So that's also available to you. Sheena, I didn't know if you wanted to say anything else COE wise.
Absolutely. So pretty much what Jay just said, that we're here. That's what our goal is to be here to help you in any way that we can. So don't be afraid to reach out. Don't be shy. Like if there's even just a quick question that you have, feel free to reach out in an email. If you want to set up a Zoom call like this, we can gather our troops together and we can have something, even if you want to meet after the holidays or something and just see how things are going. We're more than happy to do that, or just do a check-in every so often. So reach out, and that's what we're here to do, is just support you guys in any way that we can.
Yeah, this is supposed to be the primer, right? Get you guys going, get you really taken off, and then we're here to, we're hands-off approach. Obviously, you guys are in the middle of it, but we want to be there if you need us.
Absolutely.
Any other? Sorry. Stacy, thank you for the chat. Excellent job to both groups. I'm shocked Jennifer Boyd wants to do a larger project. Haven't heard that before.
I actually reeled her in prior to this. I was like,
yeah.
let's start small, please.
So any other final comments? We can, adjourn early. We really appreciate you guys taking the time, putting that information together and presenting, but any other final comments from anybody?
I just wanted to say thank you to all of you all for your, it felt like a privilege to get your hyper focus every other week for this amount of time. And it was nice. Like I had spoke to Tony about a different issue through this process. And so just really feel appreciative of your all's presence in this and throughout our work. So thank you.
Oh, Emily, happy to honored and likewise happy to help, and really likewise, we really appreciated the time that we got to spend with you all, and we know how busy you are. So taking this time out of your schedule for this amount of, this time period is not easy. We get that, and just really appreciate all the conversations we get to have. I loved our breakout sessions. Was that different this time than what we did,
Yes.
Jay, last time? Yeah, I really liked the breakout sessions. You all don't have a previous QI to compare to, but I think a lot of us really liked that. So thank you guys for your participation.
Yeah, I think both groups, you have great projects and are moving in excellent ways. And if you ever want to do another QI project, like something in different in your clinic, we're more than happy to help set some of that up with you. But now that you've walked through one, we can be there to help you, but you know how to lead it and guide it. But that's kind of what we did. We started with one, then we did another, then we did another. And so it's neat to realize that even something very basic and simple, you're like, oh, that's a QI project. Oh, that's a QI project. And so we're always here. Feel free to bounce ideas off of us or anything. You know how to get a hold of us. So with that, everyone have a happy Thanksgiving.
Yes, everybody enjoy the holiday season. Be safe and stay in touch. Can't wait to hear what's going on.
Absolutely.
All right. Take care,
Thanks,
everybody.
guys.
Thank
See
you,
ya.
guys.